Okay, well, we still have some people joining us, but I think we'll get started with our Department of Geriatric Medicine Grand Rounds. Before I introduce our speaker, I have a few housekeeping announcements to make. This CME activity is sponsored by the Hawaii Consortium for CME, a joint venture between the HMA and the John A. Burns School of Medicine, University of Hawaii. At this time, please enter the name and credentials for everyone viewing Grand Rounds for CME attendance purposes. As a reminder, evaluations are required for CME. You can find evaluations by following the link in the chat at the end of this talk or at any time on our website or email advertisement. Your comments are very important to the planning committee and will be used to plan future programs. As you know, all sponsors of CME are required to execute a conflict of interest policy. All presenters have disclosed that they have no relationships with commercial supporters that could be perceived as a conflict of interest in the context of this presentation. It is my great pleasure to introduce today's speaker. Angela Lowe completed her internal medicine residency at Stony Brook University Medical Center in Long Island, New York. She is currently starting her second year of fellowship training at the University of Hawaii. And during this year, she is also going to be doing a fellowship in medical education at JABSOM's Office of Medical Education. After she graduates next year, she's hoping to be a clinician educator in geriatrics. We also have a guest panelist for today's presentation. Dr. Nina Guerrero is the clinical director of Sounding Joy Music Therapy. Please join me in welcoming Dr. Lowe and Dr. Guerrero.
Thank you, Dr. Masaki. Thank you, everyone, for having me today. I'm just going to share my screen. Can you guys see it okay?
Yes, we can.
Okay, perfect. Thank you for having me. My name is Angela Lowe, and today I'll be presenting about music therapy and dementia. So some of our learning objectives include to be able to describe music therapy and its benefits to older adults, to be able to describe different types of music therapy, to be able to describe different uses for music therapy in adults, such as aiding in behavioral problems for those with dementia, gait impairment for patients with Parkinson's disease, and providing comfort for those under hospice and palliative care. So what is music therapy? It is the clinical and evidence-based use of music interventions to accomplish individualized goals within a therapeutic relationship by a credentialed professional who has completed an approved music therapy program. And this definition is from the American Music Therapy Association. And what do music therapists do? They assess emotional well-being, physical health, social functioning, communication abilities, and cognitive skills through musical responses. They also design music sessions for individuals and groups based on client needs using music improvisation, receptive music listening, songwriting, lyric discussion, music and imagery, music performance, and learning through music. Engaging in music has been shown to facilitate neuroplasticity, positively influencing quality of life and overall functioning. Music is noted to activate cognitive, motor, and speech centers in the brain through accessing shared neural systems. And as you can see here in the figure on the right, music affects many different pathways in the brain and many different areas of the brain. And who can benefit from music therapy? So many different people, including children, adolescents, adults, and elderly with mental health needs, developmental and learning disabilities, or Alzheimer's disease and other aging-related conditions, substance abuse problems, brain injuries, physical disabilities, acute and chronic pain, and mothers in labor can also benefit as well. The purposes of music therapy include providing structure and meaningful engagements, enhancing daily living in an individual or group setting, promoting communication and self-expression through singing and active music making, improving mood and increasing energy, encouraging physical movement through active music making, and decreasing stress and agitation through predictable, pleasurable experiences. There are many different settings for music therapy. These include psychiatric hospitals, rehab facilities, medical hospitals, outpatient clinics, daycare treatment centers, agencies who serve persons with developmental disabilities, and there's also community mental health centers, drug and alcohol programs, senior centers, nursing homes, hospice programs, as well as correctional facilities, halfway houses, schools, and private practice. And now onto music therapy and dementia care. Per the 2018 American Music Therapy Association member survey and workforce analysis, the work settings with the highest number of music therapists are in geriatric facilities. These include adult daycare, assisted living, nursing home, and geriatric psychiatric units. Music therapy in older adults living with dementia is described as a holistic approach that relies on individual strengths and needs, positively impacting mood, behavior, cognition, and mobility. It's also described as a multimodal means of expression, both verbal and nonverbal, a sensory stimulation that's personally engaging, validating, and comforting. And it's also described as a source of meaningful experiences between the caregiver and their loved one. The music therapy clinical process involves first the assessment of needs and strengths that can be activated during the process, then designing a plan of care to support short-term and long-term care goals. These may include addressing anxiety, interaction, transitions, relaxation, and physical activity. Then there's implementation, such as singing, songwriting, improvisation, use of music, moving to music to facilitate transition from the client room to the dining room for a meal. And then there's a continual evaluation of music therapy treatment and its effect on the client. There are different types of music therapy. The first two types include individual versus group music therapy. So in individual music therapy, this includes the assessment and determination of the requirements, abilities, and experiences of a client, and also includes various activities and content provided according to the client's backgrounds and preferences. In group music therapy, this includes treatment factors, cohesion, interactions among members, and experience sharing, which allow the members to receive therapeutic benefits. Then there's also active and passive music therapy. So in active music therapy, this involves active participation, such as playing in musical instruments, singing, composing music and lyrics, and perhaps discussing thoughts and feelings elicited by activities to achieve treatment goals. Passive music therapy involves listening and appreciating music to stimulate the senses and achieve treatment goals. So given all this information about music therapy, I want to also discuss how effective it can be in helping dementia patients with BPSD, or behavioral and psychological symptoms of dementia. Unfortunately, most patients with dementia experience BPSD at some point. In longitudinal studies of community-dwelling individuals with dementia, up to 97% are affected by at least one symptom, most commonly depression or apathy, although delusions, agitation, and aberrant motor behavior like fidgeting, repetitive behaviors, wandering, these occur in about a third of patients. And as a review, BPSD can include wandering, shadowing, which is when people with Alzheimer's disease or another type of dementia constantly follow their caregivers around. Then there's also night disruptions, agitation and hoarding, aggression, vocal disruption. It can also include psychological symptoms such as anxiety and apathy, depression or depressive mood, hallucination, and delusions. Unfortunately, it can be quite distressing for caregivers and the patients themselves. So what do the studies say? So this study is from the Alzheimer's Disease and Associated Disorders, published in 2008. It was a randomized controlled trial with an N of 59 from nursing homes in Italy. Here, they have an experimental group that received 30 music therapy sessions, while the control group received educational support or entertainment activities. They used NPI scores, which is the Neuropsychiatric Inventory. This takes into account the severity of different BPSD symptoms, such as hallucinations, delusions, agitation, or aggression. And this trial did show a decrease in NPI scores. The max was 36 points after 4 weeks of music therapy. In Aging Research Reviews from 2013, this systematic review and meta-analysis of randomized control trials, controlled clinical trials, and controlled trials, which are before-after studies without control, they showed that music therapy influenced BPSD in patients with dementia. The effects of music therapy on anxiety symptoms were moderate, while the effects on depression and behavior were small. The length of the intervention period was associated with the effects of the music therapy. In particular, interventions that were more than 3 months strongly decreased anxiety. The effects were small, though, in comparison to those of pharmacologic interventions, but nevertheless, the findings are promising in providing an alternate management options for BPSD. And in 2017, there was a systematic review of systematic reviews of non-pharmacologic interventions for BPSD in dementia patients. 38 systematic reviews and 142 primary studies were identified. Non-pharmacologic interventions included sensory stimulation interventions like acupressure, aromatherapy, massage touch therapy, light therapy, and sensory garden. Another group of non-pharmacologic interventions included cognitive or emotion-oriented interventions like cognitive stimulation, music therapy, dance therapy, Snows-Lynn, which is a multi-sensory environment. There's also transcutaneous electrical nerve stimulation, reminiscence therapy, validation therapy, and simulated presence therapy, which involves playing a personalized video or audio tape recording of family members to the person with dementia when he or she is distressed or agitated. The third group of non-pharm intervention was behavior management techniques and other therapies, including exercise therapy, animal-assisted therapy, special care unit, which is generally designed to provide a supportive social and physical environment for older adults with dementia, and dining room and environment-based interventions. So overall, music therapy and behavioral management techniques were effective for reducing BPSD. Here they saw that music therapy reduced agitation with a standard mean difference of -0.049 with a P of 0.003. And anxiety also did have a difference with a P of 0.002. However, the evidence supporting the effectiveness of music therapy was limited by moderate but significant heterogeneity. And this is probably related to the variability of the intervention, such as the type of music, active versus passive involvement, whether or not they were singing or playing a musical instrument, and dancing, and the heterogeneity of the patient population in terms of the severity of dementia and the type of dementia might have affected this as well. This study was published in Aging and Mental Health in 2013. It's a crossover trial of 42 participants with dementia, and this was in nursing homes in Denmark and Norway. Participants were randomized to a sequence of 6 weeks of individual music therapy and 6 weeks of standard care. They looked at agitation and quality of life as outcomes. This study showed that music therapy reduced agitation disruptiveness and prevents medication increases in people with dementia. However, because it was a small study, it does call for further research with a larger sample. And then in 2019, there is a study from the Korean Neuropsychiatric Association, which looked into 10 randomized controlled trials of non-pharm interventions for moderate to severe dementia. In the current study, non-pharmacologic interventions were not effective in reducing the overall BPSD, agitation or anxiety levels. However, in the subgroup analysis, music therapy was found to be effective in reducing the overall BPSD levels with a medium-sized effect. And with regards to Parkinson's disease and music therapy, there was a meta-analysis in 2011 that looked into music therapy in patients with Parkinson's disease. And it revealed that music-based movement therapy did show a significant improvement in walking velocity, and thus promising effects for the improvement of gait and gait-related activities in Parkinson's. And per the American Parkinson's Disease Association, they noted that music therapy may have a role in helping those with Parkinson's disease. One technique is known as rhythmic auditory cueing, in which rhythm is used to facilitate movements and improve gait. People with Parkinson's disease often note that moving or walking to a rhythm helps improve their movement, and employing rhythm to help people with Parkinson's disease is frequently used by PD rehabilitation experts. Music is a great way to provide that rhythm. And with regards to hospice, palliative care, and music therapy, there is one review of literature from 2005 that revealed that pain, physical comfort, fatigue, and energy, anxiety and relaxation, time and duration of treatments, mood and spirituality, and quality of life were positively affected by music. Unfortunately, even though there are promising benefits for music therapy in hospice patients, a national survey published in 2015 revealed that only 6% of hospices employ music therapy staff. And what are the pros and cons of music therapy? So some pros include that there is compelling data out there that music therapy can help with BPSD. It is non-invasive, it is overall enjoyable, and there's a potential to limit pharmacologic interventions for behaviors. Some cons include that there could be a major barrier for many dementia patients who are hard of hearing, so they might not benefit from music therapy as well as others who can hear. And another thing is that it's not covered by insurance. And there's also the possibility for overstimulation in our dementia patients when they're exposed to music. So before I end this slideshow and move on to questions and comments and discussion, I would like to share a clip showing some music therapy in action. So I'm just going to share that video.
Go.
What we're perhaps most excited about right now is restorative neurology, or the ability to use patterning or to use intervention to recover function in the brain following insult or following damage. As you know, the brain is the one structure of the body that doesn't regenerate individual cells. Well, the degree to which function can be recovered is phenomenal, and we're just tapping in to the extent that we can get recovery following stroke or injury or disease. We hope that music might play a particularly important role in helping those cells and helping the individual learn to interpret the pattern with those cells. So essentially to help the person learn again.
Sing my song. Can you sing it with me? Let me hear you. I believe in music. Yes.
Parkinsonism is sometimes called a kinetic stutter, and in somewhat the same way as stuttering can be helped by music, so Parkinsonism can also be helped by music, basically by giving the person an organization in time for movement and speech which they lack. The power of music, and especially rhythmically emphasized music, with Parkinsonism extends to other motor disorders, such as the sort of aphatosis and spasms, and the sort of movement called tardive dyskinesia, which Maureen has. She has all sorts of involuntary movements all over her body, and also affecting her respiration and speech. This makes it very difficult for her to function or to speak coherently, although she's a fine, intelligent woman. But music somehow brings her out of this, or it coheres all the movement, and she's able to sing beautifully. And of course the words are embedded in songs. The first discovery is that she can sing. The task is then to see if we can partly disembed speech from song, maybe get her to speak in a sing-song way, or somehow use this musical feeling to get over the dyskinesia.
I'm going to say, my name is Maureen, but I'm going to sing it to you. And if you could sing it back to me just the same way, okay? My name is Maureen. Ryan. Okay, just like that.
My name is Maureen.
Right. One more time.
My name
is Maureen Ryan. You want to keep going? Okay.
Maureen Ryan.
Very good. Thank you.
I think that embedding this phenomenon in a therapeutic relationship and a personal relationship with a therapist is extremely important. The therapist will get to know the person, the sort of music they like, and their the states of mind and emotions which are there.
Amy, good. Could you do it?
Okay, so yeah, thank you so much for joining us today and listening to my talk on music therapy. So that was the end of my portion of the slideshow and PowerPoint. But I'm here with Dr. Nina Guerrero, board certified music therapist. So we're here to answer any questions or concerns that you have, or to listen in on any comments that you might also have about music therapy.
Angela, thank you for that wonderful presentation. I'm just checking the chat to see if anybody has any questions. Oh, Patricia Lee says, can you share some stories of how this made an impact for patients you've worked with?
Yes. First of all, I'd like to thank Dr. Lowe for a very comprehensive and informative overview of music therapy. All of the research that you reviewed for us and everything, and I think it provides the perfect context to talk about some clinical stories of the impact that music therapy has in people's lives. So I think that in my experience as a board certified music therapist for over 25 years, I've had the pleasure and the honor of working with clients throughout the lifespan. So all the way from young pre-verbal infants and toddlers with their parents, all the way through kupuna in communal settings, and then the end of life. And just, kind of off the top of my head, some of the stories that stand out the most have to do with working with clients in the context of their caregiving circles, so together with their families or loved ones. Before I started on the staff of Sounding Joy as the clinical director there, I worked for several years in the behavioral health division at Queens Medical Center. And I worked as part of a multidisciplinary team, which is the best way to work, of course, in collaboration with other disciplines. So I was with an art therapist as well as with psychiatric APRNs. And we were called not only to the psychiatric units at Queens, Kekela, and the Family Treatment Center, but also to all the medical units where emotional support was needed. And there we did encounter many clients who were experiencing dementia, who might have been brought to the hospital for, a variety of medical reasons, but there was clearly a need for the support of a creative therapy modality in the midst of a chaotic and stressful environment. So I remember vividly working with one client who had suffered actually severe brain injury, and he was unable to communicate verbally and really unable to move much. He was propped up in a chair in restraints, and was frequently agitated and frustrated, understandably so, at his lack of control, and I imagine the helplessness that he was feeling. But when his family was present and I was able to engage his family members in a musical improvisation where I was able to provide improvised piano accompaniment while his daughter and his wife were given different kinds of instruments to play. I believe one of them had a tone drum, which is a beautiful resonant melodic percussion instrument where the different surfaces produce different pitches, but it's nonlinear and it's conducive to improvisation. And then, the other family member had a handheld drum or percussion instrument of some sort. And as they played together in his presence with the intention of conveying their support to him and using the music as a nonverbal means of communication, it was very vivid to see his response. He opened his eyes and he tracked from one to the other as each one in turn played. And there was a feeling, although he could not vocalize and although he was not able to, certainly to verbally communicate, he was very, very much, very observably conveying his responsiveness and his intent to engage. And afterward, I had the chance to speak as well with the family members, and they expressed how meaningful that was. And then there was another case where the patient was actually a person who had been a lifelong musician himself, and due to dementia had lost the ability to, communicate verbally for the most part, or to recall a lot of, facts or short-term memory, that kind of thing. But he and his wife were able to play, to improvise in a very interresponsive way together. So I feel that, these kinds of examples really show the power of music as a cultural resource. So, the kinds of music were not prescriptive. It's not that I selected, recordings that I thought would be, beneficial, but rather through improvisation was able to draw the family members into, contributing their own musical initiatives. It was a very collaborative process. And that example in particular, I believe he was 94 or so year old gentleman who, was in a pretty severe stage of dementia, but was able to engage in a musical conversation, if you will, a back and forth, an interresponsive exchange with his wife. Those are some of the meaningful moments. And I just wanted to point out that the use of creative modalities for therapy, be they art, music, drama, really are all about offering equitable access to therapy. So they offer both verbal and nonverbal means of processing experience, of expressing and connecting, and they are accessible and inclusive to people with a wide range of needs and strengths.
Thank you for that very comprehensive answer, Nina. That was excellent. The next question is, what are the outpatient options to get patients into music therapy? And I guess, how would you go about doing that referral?
Yes. So, another excellent question, because here in the state of Hawaii, as you may be aware, music therapy is not covered by private or public insurance. Dr. Lowe alluded to that in her presentation. And part of the reason for that is that there is no official state recognition of the music therapy profession. So music therapy is not a licensed profession here the way it is in some other states, not all other states. In New York, where I received my training, for example, the professional license was an LCAT, Licensed Creative Arts Therapy. So it was together with other creative arts therapies within the licensed mental health professions. And so music therapy was more accessible in inpatient settings where it could be part of the general services provided by a hospital, or in some cases, if working with children, in a special education setting as a related service. For outpatient options, here in Hawaii, Sounding Joy Music Therapy, the organization for which I work, is the only nonprofit music therapy organization in the state. And we raise funds to be able to provide access for those who may be limited in their financial means. We're able to offer services more accessibly, with more flexibility. But we do welcome referrals, and there are other a handful of other music therapists in the state in private practice. So I would say I just wanted to advise everyone to check out two different websites. One for the certification board for music therapists, and that lists all of the board certified practitioners in every state. Although states vary in terms of licensure within the state, there is national board certification that requires completion of accredited degree programs and also a 1,200-hour clinical internship under the supervision of a board certified music therapist. So if you go to cbmt.org, you can find a list of the board certified music therapists in our state as well as in other states. And the referral process would simply consist of making that connection and providing the relevant information and assessments.
Thank you very much, Dr. Guerrero. The next question is, what percentage of nursing homes in Hawaii have regular music therapy programs?
So, unfortunately, there are currently no nursing homes that have consistent ongoing music therapy. Our organization has served in a number of different nursing homes across the island, sort of contingent upon grant funding and upon the ability of the facilities to contribute. you know, we have a handful of facilities on the windward side that are all under the auspices of Kinaole Estates right now. That's, you know, 3 different facilities where we kind of have ongoing services. And then there are other places, you know, places on the North Shore in Waipahu, you know, Hawaii Kai, Manoa, places where we have gone with funds as available. Unfortunately, these are tough times all around. And so I think that, you know, really we all are feeling the burden to be able to make services accessible to those who most need them. And those are often those with the least ability to pay privately.
Thank you, Nina. I know there are some nursing homes who may not have actual formal music therapy programs, but who do use music therapy in various formats. Aida,
Yes.
do you want to comment on Manoa Cottage, for example, and what they do?
Sorry, what was the question?
Manoa Cottage.
Mhm.
And I don't think they have a formal music therapy program, but they
Yeah.
do use it, and so do other nursing homes.
Yeah, I mean, Manoa Cottage, actually, we have provided services there and worked with the activity coordinators. And I know that they do have a music and memory program there. And I know that Maunalani also uses music and memory. And that is actually a very interesting form of musical engagement where you know, they don't have board certified music therapists, but rather
Right.
staff are trained
Yes.
to use these resources to create personalized playlists for each individual in consultation with their family members as well, the people who know them best. And then these playlists are available in a very flexible and responsive way to help them throughout the transitions of the day. And I know Kahala Nui and a bunch of other sites are trained in this approach as well. Yeah.
Yeah,
That's
so
right.
that actually brings the question. Kevin Wu, he's the administrator over at Manoa Cottage, and he had a question about, you know, do those nursing home activity departments conducting routine singing and other music-based activities count as some sort of music therapy? I know Manoa Cottage has, like,
Yeah.
practically every activity has music in it,
Yes.
embedded. So, I mean, does that count? And
Well,
maybe Kevin can comment on some of the things that we do there.
Oh yeah, hi. Yeah, just a quick question. I mean, I think routinely we do the music and memory program. You know, I'm somewhat new to it as well, so I'm kind of learning as I'm going. But it does seem very effective with, you know, personalized playlists, and it's very flexible, so we can kind of change it up. But yeah, but we also do other, you know, just watching the clip, playing music and try to get the resident to sing along. Right.
Yeah.
But that do kind of made me ask that question. You know, nursing homes do try to do that to help with them with the breathing, especially in all of that. So yeah, not specific music therapy is, you know, would that kind of count as some form of music therapy as well?
Well, I think all of those activities and interactive opportunities with clients and the staff in all of those facilities are so significant. And I think the you know the real opportunity for board certified music therapists is to optimize our collaboration with existing music programs in these different settings, and also our collaboration with the different kinds of expertise that other, you know, multidisciplinary staff bring. So for example, when I was working in the hospital setting, the ability to collaborate with an art therapist with her specialized experience. So we would lead guided meditations with music where she would use her expertise in imagery to lead a meditation, and I provided improvised musical accompaniment as support. And it was live, not pre-recorded, but rather I was right there kind of monitoring the patient's response. And I wanted to make a point here about, the distinction between that Dr. Lowe made between passive and active music therapy. What those have in common, I would say, is the intention of being as interactive as possible. So even if it may seem like passive intervention because the patient or client is minimally responsive, as may be the case with many of the pain and palliative patients at the end of life, or other populations, working with premature infants in the NICU, for example, so they may not be able to sing or play instruments, but music therapists are specially trained to monitor the responses that they do offer through changes in their breathing, in their vital signs, perhaps in their eye gaze, as I mentioned, eye blinking, facial expressions. That's the reason that this improvisational approach is so important, because it allows for continual assessment and interresponsiveness. If we were just plowing through a song as previously recorded or something like that, it would be difficult to make those modifications based on how the patient appears to be responding. Dr. Lowe also mentioned, as one caveat, right, the possibility of overstimulation. How do we avoid that? I mean, how do we avoid overstimulation or overdose with any other kind of treatment? Well, it's through a process of continual assessment and recalibration. And that is all through the therapeutic relationship. And that's where the specialized training of music therapists comes into play. It's not to say that all of those other interventions are not contributing to the patient's well-being, but rather we all have our different roles.
Good point. And I think that leads into the next question from Jake Moore. How do you distinguish between music engagement and music therapy? Is it outcomes based? Is anyone working on guiding our nursing home staff to report these types of outcomes?
Yeah, so, I think that more and more there is an emphasis on evidence-based practice, right? So definitely documenting the interventions that are offered across disciplines in a collaborative environment like a nursing home or a hospital. The importance of team care, where each discipline is really clear on the goals and objectives that they're working toward. So Dr. Lowe mentioned, individual versus group music therapy. I want to emphasize that in both formats, we still will set individualized goals and objectives, even in working in a group. And the objectives, of course, are the measurable goalposts towards those goals, and they should be documented. And I think that's an important area of collaboration, so that we're not just offering this wonderful engagement through different disciplines, but also really clear on what, the goals are that we're working towards, and how to document the outcomes.
Does anyone have any more questions?
I think I just wanted to comment a little bit on, I think last time we had a talk, we talked about the collaboration between physical therapy and music therapy, and how that can be optimized as well if we can, like say use it with people with Parkinson's disease or something. I try to get arranged time when they're both there at the same time.
Yes.
Have them be able to teach one another or explain what they do and how they can optimize for the staff.
Yes, so it's one thing to collaborate on a multidisciplinary team, but I think that the true transdisciplinary teamwork, where each discipline is able to really benefit from the expertise of the other and to optimize overall treatment for the patient, occurs through co-treatment. right? When I was working in New York, where I did most of my professional training, I was the research coordinator at the Northrop Robin Center for Music Therapy at New York University. And one of our projects was in collaboration with the Rusk Rehabilitation Institute at NYU Langone Medical Center. And that was an opportunity for co-treatment with rehabilitation specialists from Rusk. So we would conduct a session together where, for example, working with stroke survivors, the occupational therapist would lead a series of rehabilitative exercises that were supported by improvised music provided by the music therapists. And then conversely, when it came time to pursue movement through instrument playing, the OT would lend his expertise by helping to adapt the instruments. For example, if a client was unable to grip with their affected side, he would kind of design these adaptive instrument configurations, ways of bandaging their hand so that their grip could be maintained, or techniques where they could facilitate their own movement through bilateral arm motion. And what I want to emphasize is that this kind of collaboration allowed for the integrative benefits of this creative modality to come to fruition, right? So, you know, we weren't just targeting the affected hand, for example, and doing like 50 reps of a movement that could become really tedious, but rather it was in this creative group music making environment. So it was motivating, it was engaging. The music that we offered was the client's preference, and we used improvisation, we used songwriting. They were very much invested, and each individual was encouraged to respond with their whole body, their whole mind, and to bring their emotions into it, so that you know, they weren't just working on the weak side to strengthen it, but you know, playing the drums, for example, which involves this alternate arm beating, and somehow or other, all of the latent capacities that were there were sparked. I mean, of course, we didn't have enough time to see it, you know, come to ultimate fruition. As Dr. Lowe mentioned too, the duration of therapy is important, and that's because rehabilitation and recovery, all of these processes really take time, and relationship building takes time. But we still, so, you know, speaking of clinical stories, I think in the stroke rehabilitation project, the participant who benefited most ultimately, and we had standardized measures of various areas of functioning. So upper limb functioning and impairment, sensory discrimination, cognition, memory, mood, as well as qualitative analysis of the sessions. So the patient who showed the greatest gains actually was the one who had the greatest limitations coming in. She, unlike most of the other participants, was not an elderly person. She was not an older adult. She was in her early 30s, and she had experienced her stroke in the process of childbirth. So, you know, each birthday of her child was a very poignant occasion because it was also the anniversary of her stroke. And some of, you know, the gains that she experienced were very holistic ones. So we were able to address these goals, you know, very specific upper movement or physical goals in the context of her overall well-being. She, even though we didn't really target gait in that setting because we were working on upper limb functioning through instrument playing, she still gained such overall confidence and a renewed sense of ownership of her body that she was able to give up using her cane and to have the confidence to take the subway once again. And anyone who's lived in New York knows that that is really a lifeline. That's a major milestone. And in terms of caring for her son, you know, she was very aware that as the mother, she was a single mother to boot, not just one who had experienced a stroke, but she was not able to run after her 3-year-old son because of her physical impairments. But she said when they were able to dance together to his favorite music, in that moment, they were free. And she was free to relate with him. And I think, you know, that shows the kinds of holistic benefits to both physical and psychosocial well-being that a creative modality like music therapy can offer.
Thank you so much. There's one more question. Does Sounding Joy or any other organization maintain any database of music practitioners who would be available, either free or fee-based, to offer music programs in nursing homes, care homes, foster homes, daycare programs, etc.?
So the best database would be the CBMT website itself, the Certification Board for Music Therapists. CBMT.org is the web address. Also, this reminds me, it's great to just explore the American Music Therapy Association website as well. And that is simply musictherapy.org. Very easy to recall because that will provide a wide range of resources on music therapy research with specific clinical populations, as well as, you know, answers to some of these practical questions, such as reimbursement. But, you know, in terms of, you know, personal referrals, you know, if you would like to contact us, we also do, in addition to our organization, since it is such a small, intimate community in the state, there are only about, you know, fewer than a dozen board certified music therapists statewide. We pretty much know all of them, and, you know, can also provide referrals to other people in the community.
Thank you. This has been a wonderful discussion. I want to thank both of our speakers. Very interesting topic and very useful for many of our geriatric patients with so many different types of neurological problems. So I wanted to thank Dr. Angela Lowe. Fellows presenting at Grand Rounds are always some of my favorite presentations. You did a wonderful job, Angela. Thank you so much. And I also wanted to thank Nina Guerrero. Dr. Guerrero, your knowledge is clearly very deep in this area, and it was really wonderful to hear some of your very interesting examples. And for some of you from JABSOM, Nina is the sister of our own Tony Guerrero. So she is part of our JABSOM family in that way as well. So thank you very much, Dr. Lowe and Dr. Guerrero, and thank you to our audience for listening.
Thank you so much.
Thank you so much. Thank you, Dr. Lowe, and congratulations.
Thank you so much. Thank you, you too, Dr. Guerrero.
Thank you.
Bye, thank you.